So good morning, good afternoon, and good evening. Welcome to the IFA Virtual Policy Dialogue with Dr. Samir Sinia and Mr. Anthony Leong. My name is Luana Colnago. I'm Communications Officer at the International Federation on Aging. The session is being recorded and streamed live on the IFA Facebook page. The video recording will be made available upon request. And now I'll hand it over to our moderator, Dr. Jane Barrett, Secretary General of IFA. Jane, the floor is yours.
Thank you very much, Luana. And I welcome you one and all to this very important webinar today. The ongoing COVID-19 pandemic continues to put pressure on economies as well as primary, secondary health and social care systems. Challenges in capacity remain due largely to backlogs of care built up during the acute phase of the pandemic, which then directly and indirectly impacts patients, informal care systems, and the health and social care workforce. Pandemic surges evident as we come into the winter season in the Northern Hemisphere are being realised in decreases in productivity and increased absenteeism in the workforce. We must remain vigilant, and that is why today's webinar with two key experts is so important for policymakers, the general public, and us all. Why this flu season is different and what we need to do about it. It's now my great pleasure to introduce our two speakers, and bear with me because these important experts, I would like to share a little bit of their background. The first speaker, Dr. Samir Sinia, is well known across Canada and internationally. He is the Director of Geriatrics at Sinai Health System and the University Health Network in Toronto, and a Professor of Medicine at the University of Toronto and the Director of Health Policy Research at Toronto Metropolitan University's National Institute on Aging. Samir, I didn't know that you were a Rhodes Scholar, so it's good for me to reread your bio. As a Rhodes Scholar, Samir is a highly regarded clinician and international expert in the care of older adults. He was recently appointed to serve as member of the Government of Canada's National Seniors Council and is also leading the development of new national long-term care standards. We welcome you today for this webinar. Thank you. I would also like to introduce our second speaker, Mr. Anthony Leong. Anthony is the Vice President of Public Policy and Government Affairs in Macassan, Canada, and has been with the company for over 19 years. Anthony is a licensed pharmacist by background. He oversees a team of professionals responsible for Macassan's Canada's national government relations, advocacy, and public policy research activities. Prior to joining Macassan Canada, Anthony held various consulting positions at Gemini, Ernst & Young, and IBM Canada, and was also a pharmacist owner at Shoppers Drug Mart. Please join me in welcoming both of these key speakers. The format of today's webinar is that each speaker will have about 10 minutes to actually share the status of the influenza vaccine rollout across Canada, and then there'll be a Q&A where you have the opportunity to pose questions too. So thank you, Samir. The floor is yours.
Thank you very much, Jane. I just have some slides, so I'm just going to work on getting those up right now. Welcome everybody to this webinar, and I want to just share with you a few of my thoughts over the next 10 minutes about why this flu season is different and what we need to do about it. So right now, when we actually look at the top 10 causes of death right now across our country, we know that, that since we started with the COVID-19 pandemic, it has now become our third leading cause of death. We still have more deaths from cancer and heart diseases every year in our society, but COVID-19 is now our third leading cause of death as of 2020. And that has actually shifted the other causes of death. But influenza and pneumonia, I wanted to note, still remain in our top 10 causes of death in the country. And together, these three causes of death represent vaccine preventable causes of death. And so we really need to be aware that there are things that we can do to really help lower the risk that people are getting these infections and significantly their consequences as well. So when we think about COVID-19 influenza in older Canadians, we know that older Canadians may present with COVID-19 influenza or other infectious diseases differently and sometimes have less common symptoms. So we wrote an early article, my team, during the pandemic, and it was called Typically Atypical. And it was reminding ourselves that when older people present, for example, with a sudden onset of confusion, or in the case of our article, just a fall, and that's the only symptom they have, that could actually be a presenting symptom of a diagnosis of COVID-19, for example. So we have to be mindful that older people may not present, for example, with all the typical symptoms that we would see in the younger population, but sometimes they can have more atypical presentations. But we have to realize that these infections can cause a number of different presentations, and that's why we have to be mindful that could this be an underlying infectious disease. And we know that when we look at who's been most negatively impacted by COVID-19 in particular, we know that in Canadians 60 years and older, if you look at the national statistics we have from the Public Health Agency of Canada, currently reports that still over 60% of Canada's hospitalizations have been amongst those who are 60 and older, and 93% of Canada's COVID-19 deaths, again, have still been occurring amongst those 60 and older. People will recall that at the beginning of the pandemic, the majority of the deaths occurring amongst our older population were occurring in our long-term care and retirement homes. Now the majority of our deaths occurring amongst our older adults are occurring amongst community dwelling older adults. And certainly they're having less access to vaccinations, if you will, or less ease of access to vaccinations, but also there are less public health measures that are being enacted out in the community. And so why we're seeing a big shift in terms of where our deaths are occurring, but still firmly amongst our older population. When we think about influenza in particular, we know that prior to the pandemic, influenza accounted for about 12,200 annual hospitalizations and about 3,500 annual deaths. And these mostly were being accounted for, again, amongst our older population in particular. And the same would be as if you look at causes of hospitalizations and deaths for people who are getting pneumonia. So it reminds us that these are real problems in our society. Again, they're amongst the top 10 causes of death, but in particular, they are mostly affecting older Canadians. So why is it that older Canadians are more likely to be affected? Well, this is some data from Ontario that reminds us that if you have an underlying high-risk medical condition, for example, this could put you at an increased risk for influenza, for example. So we know that when we're talking about our population 65 and older, 70% of Ontarians age 65 and older have one or more serious health conditions that puts them at a greater risk for influenza complications. But again, younger people are not immune from this. We see that even people who are 20 or 50, for example, are likely living with some sort of chronic condition, but not necessarily the vast majority until we hit our older populations. We also know that when we think about older people, we also know that many are living with multiple chronic health conditions. And so when we think about something like influenza, we know that overall, influenza can have severe health consequences, especially for those who are at risk of complications. And so these two stats, again, I want to share that for those who are hospitalized with influenza in Ontario, 67% had one of those underlying health conditions. And then as well, for those, for example, who died from influenza, again, from influenza complications, again, 67% had underlying risk factors. So it really shows us that, again, it's not just about age, but it's that idea that with age as well comes a greater risk that you might be living with underlying health conditions that can put us at increased risk of both hospitalization and death. So when we think about why are we concerned about influenza, this flu season in particular, why have our public health officials been really talking to us about concerns about this? We really just have to look to the south, and this is the data from Australia, for example, where we can actually look at what their most recent flu season indicated in the solid red line versus 5 previous flu seasons, if you will. And what we can see is that in 2019, for example, in 2017, those are the most significant past influenza seasons prior to the pandemic. And when you look at 2020, this is the dotted green line, 2021, the dotted blue line, for example, the light blue line, you barely even see them actually here on the graph, if you will. And that's largely because, well, if you look closely and see the dotted green line, you see that it's starting to do the usual flu season trend. But then by early March, when we started putting in a number of public health measures to protect all of us from COVID-19 around the world, for example, you could see that pretty much helped to nearly eliminate that year's flu season. We were thinking that there would be a twin-demic in 2021, expecting that there would be, but we still had a lot of public health measures in place. And so that really helped dampen that season. But we know that less exposure to flu over subsequent seasons, for example, can put us at greater risk. And we know now that we've lifted a number of public health measures, we've seen kind of the impact of what that had in Australia, where suddenly we had a significantly large, the biggest flu season in the last 5 years, indicated by the red line, which came early and was quite significant. So that's the concern right now. And we are seeing right now some early indications that flu, like a typical flu season, is now on the rise, for example, and there's a concern that we're going to repeat the performance of what happened in Australia, that we're going to have a more significant flu season, potentially than anything else we've seen in the last 5 years. And that's why our public health officials are really concerned about flu more so this year than ever before. So again, what are the recommended vaccines for older Canadians? Because again, we've focused a lot about getting people vaccinated against COVID-19, and there's been a lot of talk now about the new boosters, the booster doses that are out, and recommending that people get those new bivalent boosters as well to keep them protected, especially if they're older people. So certainly people are aware that for those who are older, we're recommending that not only they get their primary series, but also booster doses are required, and that might be every 3 or 6 months, for example, depending on your health status or your age, for example. And we're recommending that people pursue booster doses with one of the new bivalent mRNA boosters. For influenza, we recommend that every year people get at least, or get that annual dose of their influenza vaccine. We always want people to know that there are, yes, standard vaccines available for pretty much everybody 6 months and older, but we also want especially older Canadians to know, and then others who might be in high-risk populations, that there are enhanced vaccinations available. There's what we call an adjuvant, and there's a high-dose version. And so in provinces like Ontario, where I live, both are available. In some provinces, only one is available. And so we'll talk about that shortly. And then finally, I always remind people that, again, cold and flu season, one of the greatest complications of influenza is developing pneumonia, or one can develop pneumonia and more likely to develop pneumonia during cold and flu season as well. So we recommend that people 65 and older are getting, for example, one dose, at least one dose of the pneumococcal vaccine. And right now across the country, the PPV-23 is freely available. But NACI is now about to revise their guidelines, even recommending a different strategy with the PCV or vaccines. But right now, the PCV-13 is widely available. And again, something that people can consider for extra protection. But new guidance around our pneumococcal vaccines are available or will be available shortly. But the key thing is just not to think about COVID-19, but remembering that influenza and pneumonia are things that we can get vaccinated around as well. So right now we know part of Canada's national vaccination coverage goals is right now to have 80% of older adults get their recommended influenza and pneumococcal vaccines. Yet we know that as of the 2020-21 season, only 55% had received the pneumococcal vaccine and only 70% had received the influenza vaccine. So we're not keeping up to the targets, and we've never actually reached the targets that our Public Health Agency of Canada has suggested. So we also know that factors influencing influenza vaccination during the COVID-19 pandemic are certainly things that we need to consider. So we know that right now that 24% of adult Canadians report from a recent study that we just conducted that the COVID-19 pandemic has actually made it more likely that they're going to get their flu shot this fall. So it's great to see that more people are motivated with the opportunity to get vaccinated as well. We also know that 32% of older Canadians reported that they would be more likely to get a flu shot if their province or territory offered enhanced influenza vaccinations. So that's helpful to also appreciate that people might be more motivated if they know that there's something specifically available for them and recommended for them. And then finally, we asked the question about co-administration, because what we do know is that NACI does say that you can actually get your influenza, your pneumococcal, and your COVID vaccines at the same time. You can get them together. It is safe to do so. And when we asked Canadians, 59% of adult Canadians reported that they would get a COVID-19 booster and flu vaccine at the same time if it was offered. And so again, it gives us a good opportunity to say, maybe if we do more co-administration opportunities, that could actually help boost the willingness to get either or both vaccines. So right now, when we look at the global availability of publicly covered enhanced influenza vaccines, it's helpful to see kind of what are other countries doing beyond Canada, for example. And so right now, we know that currently in countries like Spain, Australia, Italy, and the UK, for example, they have national programs that are providing one of these enhanced vaccines, for example, and as well as in the US and Germany, for example. But right now across Canada, we know that these types of enhanced vaccines, both types of enhanced vaccines that are available right now, are not consistently available across Canada. So what do I mean by that? So this is a slide here showing that right now there are 4 different approaches to making publicly covered enhanced influenza vaccine programs in Canada right now. So this is a bit of a complicated diagram, but it really shows you that British Columbia offers one, Ontario offers both. We know that Alberta, Saskatchewan, Manitoba, New Brunswick, Prince Edward Island, Yukon are offering one type as well, for example. And then across the entire country, we do know that that right now we do have an enhanced vaccine being offered for all long-term care residents, for example, and those living in assisted living settings, so that we do have one national form of coverage, if you will, for a select population. But we also know that there are certain provinces and territories like Quebec, Newfoundland, Nova Scotia, the Northwest Territories, and Nunavut, who are not offering an enhanced option for their community dwelling older adults. So again, as we're saying, we have a bit of a patchwork process, unlike some of the other countries I mentioned, where there is actually a national coverage scheme available for community dwelling older adults and those living in congregate settings. So I wanted to mention as well that, again, as that Canadians are very interested in co-administration. And as I mentioned, Massey has advised that we can safely take the COVID-19, influenza, and pneumococcal vaccines together. And so we need to better encourage, enable, incentivize healthcare providers to safely co-administer vaccinations to help their patients make it more convenient for them to stay up to date with their recommended vaccines. And I'd like to see more effort around this happening, because certainly in my clinic and in my practice, for example, I've been asking my patients, hey, when you made that appointment for your COVID-19 booster, did they offer you an influenza vaccination at the same time? And I had my 100-year-old patient's granddaughter said, Dr. Sinha, they didn't even mention it. And had I known that we could co-administer it, that would be helpful. Because she said at the pharmacy we went to, they asked us if we had received a vaccine within 14 days, almost making me think that you couldn't do it. And so often I feel like I'm having to remind my patients that to ask for that and make sure that to advocate so they can make it easy, because for many of them to get to their primary care provider's offices or a pharmacy, it means 2 trips, it means a lot of extra effort, and many of them are willing to get co-administration, but we're not actively doing it, as I can see, as much as, say, other jurisdictions where they're actively promoting co-administration and making it easy to do so. So I think that really gives us some lessons here for what we can do to not only improve access to more enhanced vaccines and just vaccination in general, but also kind of strategies which we can actually do that as well. And so with that, I want to thank you for your attention, and I will turn it back over to Jane, our moderator.
And thank you very much, Samir. And that's the beauty of the person that you are. You're at the front line, you're seeing patients, you've got the science behind you, and you'll be able to articulate the importance of vaccination across the life course, but also advocating for those that really are most at risk. Before I hand the floor to Anthony, I do just want to pick up on a couple of points and pose a couple of questions. You have alluded to the fact that, globally, adult vaccination is suboptimal. That's not a new fact. And within Canada, it's no different. I was surprised that the target is 80% and we've never reached that. We've got to ask the question why. But we also know in Australia and the United Kingdom, keeping in mind the health systems are different with varying incentives and varying vaccines offered. I know Australia has a harmonised program, which means that whether I'm in Western Australia or Victoria, then I have access to the same vaccines and processes. Do you think Canada should up its game and become more serious about doing better for seniors and work to improve vaccine coverage outside of long-term care? So perhaps you can, just respond to that question.
Yeah, I think what we've realized, and so our NIA did actually a report the other year looking at early on during the vaccine rollout to look at how Canada's rollout actually went compared to other countries around the world. And what we really saw was that when you actually have speed, when you have targeting, for example, and you have that national coordination, for example, you get really good results. And we should really be proud overall of how well we did, because when you look at a lot of people were saying, oh, older adults are hesitant, we've never gotten above 80%. But we have to remember, we smashed through all those records, including even the booster shot. We have over 82% of older Canadians who've gotten vaccinated against that. So can we break that 80% barrier? Easily, but that's where we had a national coordinated approach, towards our COVID-19 vaccine rollout. The reason why we actually have a national coordinated approach right now to getting enhanced vaccines to everybody living in a long-term care home is because the federal government has picked up the tab. They actually told all the provinces and territories, we're buying the vaccine for you, it's here. But that program has been in place for 2 or 3 years and may not be renewed now. And it may just then go back to our provinces and territories to figure out what they want to do and how they want to do it. But again, it reminds us that we are capable very much of collaborating, coordinating, and having one strategy, because the challenge is that we don't live in a bubble in our own provinces and territories. People start saying, wait, why is that vaccine available there and not here? And then we create undue confusion. But at the same time, if we're not also, enhancing our messaging, reminding people about co-administration, other things, having that national kind of rollout and effect allowed Britain to finally smash through that 80% record. They had 85% of their population vaccinated last year against influenza, and I'm sure that they're actually going to reach that target again because it was a national rollout. It was coordinated. They incentivized the right providers to be involved, including getting their pharmacists involved and primary care providers. And it really shows what a good coordinated approach can do to make sure that more of our population is protected and not unduly harmed as well.
Look, you're quite right. And I will just add another question, because you did raise this whole, the federal government that funded the National Seniors Influenza Vaccination Program in long-term care. And the concern that many of us on this webinar today, and policymakers should be concerned also, is that they will not continue that, which will mean that it will be up to the provinces. I've got to ask you, is this a good return on investment for the federal government or provincial government, to invest in vaccines specific to seniors across the board, whether they're in long-term care or whether they're living in the community? What would your business case, what would you say to the Minister of Health and Finances on this call?
Yeah, so I mean, overall, what we do is we have quite compelling data now showing, from other, from around the world, that again, that there's a reason why there are different formulations of influenza vaccinations, right? And I think the key is, first of all, a vaccination is better than no vaccination, but there is growing evidence showing that these enhanced vaccines that are developed for older adults or other populations actually do show clinical benefits significant enough to say that it's worth actually funding these programs. And certainly some of the larger provinces across the country who've had the time to look at the evidence and look at the economics around this know that there's value. Certainly our federal government, noted that there's value in making sure that all of our folks in our long-term care homes are protected as well as possible. So there is, I think, ample evidence to show that there is good value for money for promoting this. But again, you don't get a return on investment if people don't actually take the vaccine you have. I think what we've seen is that our governments, continually order vaccine, but if it doesn't get into the arms of the people who need it, then you're not getting good return on investment. So that's why it's not just about covering a vaccine, but making sure the people who would most benefit from it get it as well. And I think this is where I see a better opportunity for us to look at how are we rolling this out, how are we incentivizing and making it easy to do the right thing, which is, in my view, offer co-administration opportunities, make sure that everybody who can provide vaccinations is doing so. So in some provinces, our pharmacists are not enabled to deliver vaccinations, and that just makes it more inconvenient and puts more burden, for example, on primary care providers. So how do we make this the business of everyone? How do we give the public, clear, accurate information, and so that we can really support our uptake? And I know we can do it because we've done it with COVID. So why can't we do it now, coordinating this for influenza as well?
Okay, and thank you. And you're really talking about some policy change there, taking the lessons that we learned from COVID and actually implementing them and scaling them up. You mentioned, pathways and processes and supply and demand. So it's now my great pleasure to hand the floor to Anthony Leong, Vice President of Public Policy and Government Affairs at McKesson Canada. Anthony, the floor is yours.
Thank you very much, Jane. And I'm just going to put my slides up. So thank you, everyone, and pleasure to be here today. So what I'm going to talk about today in terms of seniors' access to seasonal flu vaccines is really how distributors, pharmaceutical distributors and pharmacies help drive the access. And just in terms of who McKesson Canada is, for those that are unaware, we're a leading healthcare solutions provider that works nationally across the country. And what we do is basically ensure timely access to medications to patients. And we do that in a number of ways. So we're one of the largest pharmaceutical distributors that basically ensure that community pharmacies and hospitals receive timely access to any pharmaceuticals or vaccines that they require. And we also support different practices of pharmacy. There's 2,300 independent pharmacies that basically participate in our banners. So if you see an IDA, Guardian, Remedies, Proxim, Uniprix, those are all independently owned pharmacies that we help to compete against larger pharmacies and provide the best patient care to their customers. We also are the owner of Rexall pharmacies, so best-in-class pharmacy services and convenience across the country, 400 locations. And then we also provide an end-to-end patient support model for specialty medications. So these are usually complex therapies. We provide the pharmacy services to support those, which are a little bit more intense than what you find in the traditional pharmacy, as well as we support injection training and infusion services at our infusion clinics across the country. So all these things really work together to make sure that the medications get from where they are to where they need to be and to the actual patients themselves. And so in terms of, during COVID-19, I think really there was an opportunity and we saw how pharmaceutical distributors and pharmacies actually really came to the forefront during the pandemic to really make sure that, Canadians got the vaccines and the medications that they needed. And for pharmaceutical distributors, I mean, pharmaceutical distributors are not really something that a lot of people think about. And really, it's an invisible network that's across the country that McKesson Canada belongs to, along with other pharmaceutical distributors. And really, what this invisible network does is it really streamlines the movement of drugs between hundreds of manufacturers to thousands of pharmacies via low-cost and efficient models. So you really think of it as an hourglass. You have hundreds of pharmacies hundreds of manufacturers on one end, 11,000 pharmacies at the other end. And without pharmaceutical distributors, essentially, each of those hundreds of manufacturers would have to basically ship small shipments to 11,000 pharmacies. And so you can imagine pharmacies being inundated with hundreds of little boxes coming in with hundreds of invoices that they'd have to pay. And so, of course, that would be very unwieldy. Instead, you have the pharmaceutical distributors in the middle, so the manufacturers only have to ship to maybe a few dozen distribution centers, and then each pharmacy, they can basically order everything they need from their primary distributor or their secondary distributor if need be. So it really simplifies it. So essentially, pharmacies make one order, they get one shipment, and they pay one invoice. And of course, pharmaceutical distributors like McKesson Canada, we visit almost every pharmacy every day. And we're also a short-term buffer against drug shortages. So we will carry anywhere from 3 to 6 months of inventory of pharmaceuticals, such that if there is a short-term, supply disruption from a manufacturer, there's enough inventory in the system that hopefully that will give them, anywhere from 3 to 6 months to fix that issue, and hopefully there won't be that disruption impacting the patient. And so in terms of, during COVID-19, pharmaceutical distributors actually distributed about 20 million doses of COVID-19 vaccines to pharmacies and other immunization points. And not only that, but also we distributed rapid tests, some of the COVID-19 antivirals and other therapies for COVID-19, such as hospital-based therapies. Pharmaceutical distributors also protected Canada's drug supply from the overwhelming demand in the early days of the pandemic. So in March to June of 2020, it wasn't just toilet paper that people were running out of. It was actually, pharmaceuticals. There was overwhelming demand. There was basically everyone tried to refill their prescriptions all at the same time. And that could have actually depleted Canada's drug supply within a month. But the pharmaceutical distributors stepped in working with the manufacturers to actually put filters and historical allocations in place such that, the first 100 pharmacies and hospitals, for example, didn't buy up everything, leaving nothing else for everyone that came after. So there was equitable distribution of those scarce drugs during those dark days. And also pharmaceutical distributors also played a role in terms of another procurement source for governments when they were in search of PPE during the early days of the pandemic, as well as rapid tests later on. And then pharmacy, of course, pharmacy, there's 11,000 points of care accessible to patients in urban, rural, and remote settings all across the country. And of course, they're open evenings and weekends. Pharmacists certainly are experts in drug therapy. And some provinces have also expanded the scope of practice such that pharmacists can deliver some additional primary scope of primary care activities. Some of them can prescribe, such as, for example, for minor ailments, which is coming to Ontario in January, and PEI pharmacists just received that recently. And of course, pharmacies have been a growing access point for a number of immunizations over the last decade. And so during COVID-19, pharmacy administered over 18 million COVID-19 vaccine doses to patients and offered a number of other services to support during the pandemic, such as asymptomatic testing, take-home rapid tests, and offering, for example, Paxlovid, the COVID-19 antiviral therapy. And pharmacies also stayed open, during the. In some community, we're probably the only accessible healthcare provider during the worst parts of the pandemic. And they also collaborated with suppliers and physicians to help manage and mitigate the patient impact of any drug shortage that were encountered during COVID-19. And so, of course, with the key role that pharmaceutical distributors and pharmacies play in day-to-day life, they also are, of course, a key enabler for access for seasonal flu vaccines by seniors. So for pharmaceutical distributors, I mean, essentially, there's an efficient distribution model that's in place for public flu vaccine, getting them to pharmacies. That's in place in 7 provinces, and it actually first started in 2014 with actually, I believe it was Alberta and Prince Edward Isle, and now it's expanded to 7 provinces. And so what this does is this ensures a predictable supply to the pharmacies and a higher availability at the pharmacy, fewer out of stocks, such that when patients show up, there's less chance of the pharmacy being out of stock, and so the patient can get their vaccine right then and there. And how is this achieved? Well, essentially, we have just-in-time delivery and frequent replenishment, in previous to the pharmaceutical distribution model, essentially, a lot of pharmacies actually had to drive out to their local public health unit, or maybe they get shipped from public health, and there might be 4 weeks between your shipments. So essentially, when you place your order, you're gonna have to guess how much you're gonna need over the next 4 weeks, and sometimes you overestimate, sometimes you underestimate. And so when you overestimate, you potentially might have more end of season waste at the end of the season. I mean, I used to work in a pharmacy, and sometimes some years they overestimate how much they need, and so you might have something like 2,000 doses left over at the end of March because they overestimated how much they needed. And of course, once the vaccine lands at a pharmacy, it's very hard to transfer to another pharmacy. So you end up with stranded vaccines. And so with the pharmaceutical distribution model, where the pharmacies only order what they need, say for the next week or so, you're better able to match, the supply and demand. Also, another challenge in terms of pharmacy had to go back in the old days to go pick it up at the public health unit. Essentially, it could sometimes be a 2-hour or 3-hour drive to the nearest public health unit if you're out in the rural or remote areas. And so you'd have to bring a cooler and hope that the vaccine will stay within the 2 to 8 degrees Celsius temperature range during that trip back to the pharmacy. And of course, that also takes time out of the pharmacist's day. That they, instead of actually immunizing patients, you're actually spending 4 hours on the road. And so certainly, with the pharmaceutical distribution model, the cold chain integrity is kept because we have Health Canada validated cold chain packouts that can get these vaccines to the pharmacy doorstep at 2 to 8 degrees Celsius. And certainly pharmacists, don't have to drive out to public health units. And so, certainly I think this also encourages more pharmacies to participate. And as the pharmaceutical distribution model has rolled out for flu vaccines, we've seen in numerous provinces, the number of pharmacies that sign on to this actually grows quite dramatically. And then, of course, pharmacy, they've been administering public flu vaccines since the mid-2000s, and it's actually the fastest growing channel amongst all the immunization points in every province. And of course, pharmacies are the most convenient immunization point, with so many locations and longer opening hours. I can recall covering, Christmas shifts in a pharmacy. One year there was really, a second wave of flu that hit the community. And, between Christmas and New Year's, there was suddenly a huge uptick in demand for a lot of patients looking for flu shots because their family doctor offices were closed for the holidays. And really the only place they could get something was actually the pharmacy. And so, of course, the pharmacy were happy to administer those doses. And it was great that we were there to provide those doses. And of course, I think pharmacies are probably the most frequently visited healthcare provider amongst patients, and particularly among seniors. And I remember when I used to own my Shoppers Drug Marts in Hamilton and Scarborough. I can recall, there were a group of seniors that actually would come into the store almost every day. It was part of their normal routine. They come talk to the staff, they meet their friends, they look at what's on sale. And so, it's not surprising that, there are statistics that show that, some patients will visit their pharmacy 35 times per year. And, couple that with a strong relationship with the pharmacist, that means you've got that many more opportunities that when you see Mr. Jones or Mrs. Smith coming into the pharmacy, you can say, hey, have you got your flu shot yet? Have you got your COVID shot yet? You want to get them now. It only take 20 minutes. And so you've got a lot more opportunities to help patients make that decision. And of course, pharmacy now accounts for over half of the flu vaccines administered amongst all the channels compared to, say, public health, family physicians, and whatnot. So certainly it's a huge channel. And but of course, I think there's still more opportunities out there to improve the pharmacy immunization model to help improve access for seniors. And I think some of the challenge that we see every year is that at the beginning of the year, demand usually outstrips supply. Everybody wants to, the early adopters, everybody wants to get to the pharmacy and get their flu shot first. And so pharmacies sometimes they will run out because of the overwhelming demand. And sometimes we also see actually later in the season maybe public health or family physicians order too much vaccine, and so there's some vaccines that are stranded. And sometimes our pharmacies like Rexall's get calls from their local physician office saying, hey, I've got 1,000 doses sitting in my fridge, can you make use of them? And so I think some potential solutions, policy solutions, are that to cut down the cycle time to get the vaccines from the manufacturers to the pharmaceutical distributors and to the pharmacies, have the vaccines shipped directly to the pharmaceutical distributors instead of passing through, provincial vaccine depots first, because that usually will add a day or two to the whole, handling time. And so, let's get those vaccines to the pharmacies ASAP. Also,
Anthony,
I think that,
can you just start wrapping up? Thank you.
Sure, absolutely. And we can also, allocate more doses to the rapidly growing pharmacy channel, particularly during the first 4 to 6 weeks. And I think governments can hopefully share their program plans earlier in the year so that pharmacies can better be prepared. And also, I think there's an opportunity to get more pharmacies involved in seasonal campaigns. And I think making pharmacy a vaccination destination for all routine immunizations will help to actually encourage more pharmacies to participate in flu vaccines, because they're not just ramping up their staff and resources for 6 weeks out of the year or 8 weeks out of the year. They're doing it all year long. So I think it'd be a lot easier for them to participate in flu vaccines. Also, other things like expanding technician scope of practice to include immunizations, streamlining pharmacy billing and data collection, as well as improving public reimbursement for pharmacists that administered vaccinations would also help to encourage, instead of just 75% of pharmacies participating, let's get 100% of them participating. And that's it. Thank you very much.
Look, thank you very much, Anthony. As you can see, both of these expert speakers, have key messages to inform policymakers as well as academics, NGOs, patient groups representing those who are most at risk. Anthony, while we wait for some questions to come in from our attendees, I just wanted to really go back to, what Samir, Dr. Sinha said when he talked about not all provinces offer vaccines that are specific to seniors. And in your experience from McKesson and also McKesson Canada, and also from your pharmacy, in those provinces where the policies, the provincial government do not fund those specific vaccines for seniors, what happens? Do people pay out of pocket or do they just forget about it?
Yeah, that's an excellent question. And actually, our frontline pharmacy staff that do see this in those provinces. And what will happen is that the family physician or the senior will say, you should go to the pharmacy and get this high dose vaccine. And then when the patient shows up and they're explained that, it's not covered under the public plan, and you'll actually have to pay for it out of pocket. A number of them actually will decline. And they will actually wait. They'll actually end up just going for the regular flu vaccine, which doesn't offer as much protection, but they do find the cost prohibitive. And certainly, I think that is a gap that can certainly be addressed.
I think we go back to what Samir has been talking about, older people and older people with chronic comorbid conditions. It seems as though that population, which is very large in Canada and growing, is almost playing Russian roulette. Samir, what were your thoughts on that?
I think this is the challenge because, again, if we say, what is our public health goal here? We want to keep all of our folks healthy and well for as long as possible. It really begs the question as to why other countries, and of course, as you said at the beginning, was that, it's one thing to compare ourselves to other countries that might have national immunization systems. But at the same time, if you look in the United States, like with Medicare, for example, it's one national system. Even though the U.S. is a very patchwork system, when it comes to older people there is a national system saying this is what's covered, for example, and this is where you can get these vaccines. So there are ways in which we can actually look at doing this. And the example, as we mentioned earlier, was there was kind of saying this is what we're going to do for this vulnerable population living in all of Canada's long-term care homes, and all of our provinces and territories are more than happy to participate when you're not picking up the tab. I think the key is, we need to look at the economics. Is there a cost benefit here? And how do we to Anthony's points, how do we make sure that we get everybody involved so that there is no wrong door, but we also make sure that we're actually using our supplies wisely and using our available vaccinators wisely as well? Because what I end up seeing is, Britain last year, got 85% of their older population vaccinated by having a much more streamlined, clear vaccine rollout. And yet we're still kind of, pushing against that 80%, hoping to get there, but we seem stuck here. And so I think this is the opportunity where we've seen that by improving policies to access, such as allowing pharmacists to be able to deliver vaccines in certain provinces, we see that there's greater uptake. Where we see when these vaccines are publicly covered and funded, we see there's greater uptake. So we know what we need to do. I think it's just an opportunity to have a serious conversation about saying, how do we do this, especially learning what we have from the COVID-19 rollout and what was successful about it.
Look, thank you. We have a question from Colette Benbow that I'm going to read out on your behalf, Colette. An issue with ordering vaccines that were specifically designed for seniors for a subgroup of the population and with numerous immunisation points, over 3,000 in Alberta, is dilution of supply and getting enough vaccines for the population to each immunising site. Increasing access points makes good sense, but it only 20 to 40 doses of vaccine can be distributed to each site. It does not help each site deliver the vaccine. So really, it's about the allocation of vaccines to a myriad of sites. do you have any suggestions to improving the dilution of supply? Anthony, I think that's one of your questions. Do you have any thoughts about that?
Sure. I mean, I think, in some provinces, they actually allow pharmacists, to administer flu vaccines outside of the pharmacy. So, usually most long-term care facilities do have a pharmacy that services all their medication needs. So, just if a pharmacist can go, to the actual facility, bring some doses that they've received from their distributor, they can administer those doses, and then, whatever's left over, they can bring them back to the pharmacy and use them for other patients. But I think, that's one possible solution is, leverage the pharmaceutical distributors and the pharmacies to help, reach all those different little locations, and I guess concentrate, the doses where they can, make the most use.
It seems to me that I can remember the tents. Can't we remember the tents and everybody lining up? And there was just this immense urgency because, COVID really exposed inadequacies in our healthcare system, pushed frontliners, and it seems as though it's back to normal, isn't it? It's flu season, go and get your flu vaccine. And we don't have simplified pathways to the vaccine. We don't have adequate awareness campaigns that are targeted to at-risk populations. And that's good public policy. It's just good. And it's low-hanging fruit. Targeted messages and campaigns is what we need. We've just got a couple of more minutes before I'm going to hand it back to our speakers for their takeaway messages. I'm just going to, okay. Stefania Maggi, dear colleague and friend in Italy. So Stefania is posing a question to you, Dr. Sinha. NACI in Canada suggests that high-dose vaccine has the highest evidence of efficacy in older adults. Is this taken into consideration in the policy actions? That's a tricky one. I knew that we'd get a tricky one for you, Samir. So over to you.
No worries. So right now, NACI's statement around influenza vaccinations is from 2018. And so certainly was looking at all the available evidence they had at the time. And again, indicating that compared to standard dose vaccinations, the high dose vaccination is what's recommended for older populations. Absolutely. More recently, and I think that has been reflected in certain kind of decisions. You see more access to that vaccine, for example, in a number of provinces and territories, and is being used for the national rollout, if you will, in our long-term care homes. Right now, we know that when you look at countries like Australia, Australia, Canada, sorry, I'm getting my countries mixed up right now, but the United Kingdom and other countries where we look at those national rollouts, for example, some of the latest evidence that has come out, and I think is best reflected in the ACIP statement, that's the American equivalent to NACI, looking at all the evidence basically says there are other enhanced vaccines that are available, like the adjuvant vaccines, the high-dose vaccines, and basically they're pretty much seen as being equivalent, non-inferior to each other, and they are better than a standard dose. So the key is, I think that's partly why, Ontario, for example, has said for supply issues, we're going to have these two available. You have British Columbia that has said that they're going to go with the adjuvant available. So I think the policies are reflecting the science. But I think back to your point, Jane, and I think what Anthony said is that we still have a lot of logistical hurdles and messaging hurdles that are getting in the way of us actually even getting the doses that we are making available into the arms of the right people. And I think that's my message, is that the science is guiding kind of decision making at a high level, but we're still not seeing that goal of 80%, including in the provinces where these vaccines or any vaccines are available.
Look, thank you for that. And that's very clear. In the middle of the pandemic, we all knew the vaccine that we had just received. It was AZ, or it was Pfizer, or it was Moderna. I mean, clearly that they weren't the names of the vaccines, but we knew. And that says to me that we need to be asking questions of the of those that are administering the vaccines. what vaccine, I'm in this age group, or I have this chronic condition, so therefore I am eligible for X. And I think we need to be really clear that the logistical barriers can be overcome because we've done it before. And now is not the time to stop. Now is the time to be much more vigilant and put in solutions from a policy perspective, but also be responsible for asking those questions. Now it's my time to, as we come to the hour, thank you very much for being with us. I want to hand it back to Anthony, first of all, and then to Samir for your closing takeaway message about this particularly important webinar. Anthony?
Thanks. I think, the pharmacy channel is a very great channel for seniors to get access to flu vaccines and other vaccines. So, let's capitalize on that. And so, let's try and, allocate more flu vaccines to those channels such that, the seniors will be able to get them from the most convenient location. Let's try and get them to the pharmacies as quickly as possible. Just try and minimize the time delay for handling. And I think, let's try and get more pharmacies involved in immunization programs. Not just for flu, but let's get them involved for routine immunizations, such that, instead of only 75% of pharmacies participating, let's get 100%. So that'll be even that much more points of access for seniors. And I think that'll certainly help to boost the immunization rates.
And look, thank you, Anthony, for raising that issue. We know that in recent times in France, the policy position is that pharmacists can actually vaccinate, throughout the life course. And I think that is an incredibly effective mechanism for qualified vaccinators to be able to access and administer across the life course. So Samir, your takeaway messages.
Yeah, so one of the stats I didn't share was that when PHAC did a survey, the Public Health Agency of Canada, they asked Canadians, are you up to date on your vaccinations? And 88% of Canadians said yes. And the reality was only 3% were. So right now, we're not doing a good enough job letting people know what they're eligible for. But the good news is that we know that many older people are well aware that there are different choices of, COVID vaccines, influenza vaccines, that there are different options. I think what we are hearing right now is that we're not doing a good enough job reducing those barriers to access. So really promoting opportunities like co-administration. I went into our local pharmacy the other day to go get my COVID vaccine, and they said, sorry, Dr. Sinha, we can't give it to you. You have to actually make an appointment. Can you go back to your office and book it online? And I thought, oh my God, I want to get both my influenza vaccine and my COVID at the end of a shift. And they said, go online and try and book something. So I thought that was a missed opportunity even for me to get actually vaccinated. So what are we doing for our older people? So I think we have heard, some great ideas today. And I think it's making sure that people are aware of what they're eligible for. We reduce barriers, and we make sure that we make sure that people have access to the vaccines that will be best for them.
And thank you very much, Samir. In closing, of course, to our expert speakers, thank you for your intelligent and thoughtful comments, for your preparation, and for really being at the front line from different perspectives. Today, we've heard that certain influenza vaccines have been designed specifically for populations, older people and those with immunocompromising conditions at risk and life-threatening complications. Regrettably, we also know from this webinar that recommended vaccines are offered by some but not all provincial programs. And we have an overhanging decision that is going to be made by the federal government, around vaccines, particularly for residents in long-term care. They have the right, it's a human right, to be able to access vaccines. So many older Canadians do not have access to these free vaccines specific to them. This webinar was to encourage decisive policy action. Our experts highlighted the influenza vaccine offering scientifically better protection for at-risk populations. We also talked about the logistical barriers, the low-hanging fruit, that all of us as advocates and representing patient and other populations, we can advocate for change, those simplified pathways, the expansion of those that can administer, cost, the universal opportunities and the right for vaccines across this nation and across our life course with specific attention to older people. This is what this webinar was about. At the very least, go and ask the questions about the vaccines that are available and you as individuals have access to, because now is the time not to decide not to have the vaccine. It's the time to decide to be vigilant and be vaccinated. In closing, once again, thank you to you all for being here. I'd like to thank Luana, IFA staff, for your endeavours and for the charismatic way that you present, these webinars. It's a pleasure to work with you. And also to Seqirus for their unrestricted support in funding to host this important webinar, and also to Hill and Knowlton, whose support along the way to make this event what it should be. So thank you very much. Samir, particularly thank you to the National Institute of Aging for the work that you are doing, very important policy papers, and we encourage all to go to the internet, access the NIA website, because they are really foundational papers that are worthy of reading. So thank you, be well, and we look forward to being with you once again. Bye-bye.